Greetings, I'm Jim Shea with the Acoustic Neuroma Association, and I'd like to welcome everyone to the ANA presentation of post-treatment issues and side effects in acoustic neuroma patients with the team from Cedars-Sinai Medical Center in Los Angeles. Dr. John Yu, Dr. Mia Miller, and Dr. Matthew Lee will introduce themselves in a moment. First, I'd like to handle a few quick items. Captions are available for this presentation. You can turn those on at the bottom of your screen. Also, a reminder to keep an eye on our social media, particularly as this is ANAwareness Week, for all the informative posts on Facebook, Instagram, and even LinkedIn. It's a terrific way to learn about all the resources we have available and how you can be more involved with the ANA. As we always say, we're here to help, so we hope that you will access those opportunities. And now, doctors, if you'd like to introduce yourselves, we can get started.
Hello, everyone. I'll begin. My name is Dr. Mia Miller. I'm the Neurotology Director of the Cedars-Sinai Acoustic Neuroma Center. And I will be speaking with my colleagues, Dr. Yu and Dr. Lee. Would you like to introduce yourselves?
Go ahead, Dr. Lee.
Hi, how are you? I'm Dr. Matthew Lee. I'm a facial plastic and reconstructive surgeon here at Cedars-Sinai.
My name is Dr. John Yu. I'm the neurosurgical director of the Acoustic Neuroma Center at Cedars-Sinai Medical Center. And I'll be talking about neurosurgical complications of acoustic neuroma surgery.
Okay, wonderful. So I'm going to share our presentation. All right, can everyone see that? Excellent. Okay, so we're really honored to be here today as part of Acoustic Neuroma Awareness Week. And we have a multidisciplinary team at Cedars-Sinai for the complete care of patients with acoustic neuromas. Dr. John Yu is my neurosurgical partner, as he just said, and Dr. Matthew Lee is actually our facial plastic surgeon and facial nerve expert, which is a really important piece of our center. And so as a team, along with some other parts of our team, we manage both the care and the post-treatment, either complications or other concerns that patients have after acoustic neuroma treatment. So this is just our website page, just in terms of introduction. We can find all of our team members attached to this page. And we also wanted to introduce our patient navigator, whose name is Maria Bihis, and this is how to reach her. So her job is to really help orient patients to the entire treatment process. She also is really helpful post-treatment with any concerns that patients have, because she can connect our patients with any doctor and knows where we are at all times. And so she's a really critical part of our team. So I really didn't want to spend too much time on background. As many of us know, acoustic neuromas are diagnosed in roughly 1 to 3.5 out of every 100,000 people a year. So it's a pretty rare tumor. And the main management strategies include observation, microsurgery, and radiosurgery. Post-treatment complications can happen both after microsurgery and after radiosurgery. And the way that we approach those at our center is through a multidisciplinary team with a lot of different providers with different talents and knowledge bases, so that we really have complete care for our patients. So we only have 3 of our faculty speaking today. I'm a neurotologist, so I'm going to be discussing improvement in postoperative hearing and improvement in balance. We do have Dr. Ted Cho, who is our balance expert, and he has another webinar that's accessible on the ANA website discussing balance rehabilitation in particular. Again, Dr. Lee is our facial nerve expert, and then Dr. Yu helps with all of the neurosurgical care both during and after treatment. And then he's going to touch on radiosurgery as well. We're going to focus on complications after surgery, microsurgery, but we will touch on some radiosurgery concerns. So to dive right in, when we talk about hearing improvement after surgery, if there is hearing loss after surgery, you can either have a standard hearing aid or a cross hearing aid. We're going to go over the differences between those. There are bone-anchored solutions. So these are implantable devices that help with hearing after acoustic neuroma surgery. And even more recently, cochlear implantation has also been used after acoustic neuroma surgery. It used to be that cochlear implants were not done after acoustic surgery and really just done for people who had hearing loss apart from this acoustic neuromas. But more recently, there has been some research in this area and some success, and we'll talk about that a little bit. So just to review again, there are different surgical approaches that have different effects on hearing, and that really leads us to different hearing rehabilitation processes. So with a translabyrinthine approach, we know that we're going to sacrifice hearing. This is for larger tumors or those with poor hearing. So there are very specific ways we improve hearing when we know that the hearing is going to be gone after surgery. And so we'll touch on that. For the retrosigmoid or suboccipital and the middle fossa approaches, these may preserve hearing. And in that case, they may do either a partial hearing preservation or a complete hearing preservation where hearing improvement is not needed. But sometimes hearing preservation surgery does result in a decline in hearing, even though that hearing is usable. And so we'll discuss those situations as well. So, what is hearing preservation? If you have some hearing in an ear, that's not good enough. You really have to have enough hearing in the ear that if you were to put a hearing aid on the ear, it would work. And what does that mean? That means if you hear at a level better than 50 decibels and better than 50% word understanding. Now, this is sort of the classical definition. There are patients who have a lot of success wearing hearing aids with slightly lower word understanding scores in the 30s. But if you have a very poor word understanding score, like 10%, that's really not a hearing preservation outcome, because a hearing aid won't be useful in that case. And so the first line for hearing improvement is always a hearing aid. If we can use the ear in which the acoustic neuroma was removed and put a hearing aid on that ear and improve hearing, it is always our first choice, because then you have 2 useful ears rather than 1. And so it's important to understand a little bit of hearing is not quite good enough. So what happens when you don't? So if you either have a translabyrinthine surgery or a surgery that is meant to be a hearing preservation approach, but the hearing is not preserved, what we do is we often route sound to the other ear. So as you can see, this is a diagram looking at cross hearing aids. And essentially what a cross hearing aid does is, you can see it takes the signal from the poor ear and it routes it to a device in the better hearing ear. And what this does is, when you're sitting at a dinner table and you can't hear someone on the side that you have lost hearing on, it helps you because it gives that sound to the other ear. A bicross hearing aid is very similar, except that it also amplifies. So if there's some hearing loss in the better ear, it makes that a little bit louder as well. So this is a very good solution. It's a non-surgical solution for single-sided deafness or hearing loss after acoustic treatment. This, interestingly, is sort of an old picture of what a cross hearing aid used to look like. The device now uses Bluetooth and does not have a wire, but this was an early model where they were actually connected together. So with a cross and bicross, you're wearing 2 hearing aids, but you're really only receiving signal in 1 ear. So moving along to the bone anchored devices. So you may have had someone do a tuning fork test where they put a tuning fork to the skull, or you can hear vibration sometimes if that's on your teeth or on your skull. And so these devices use the property that if you vibrate the skull on one side, you can hear it on the other. And so what this does is, with the bone anchored devices, we put an implant on the side that is deafened after acoustic neuroma removal, and it routes the sound to the other side. So again, this gets over the head shadow effect. So if I had surgery on this side and I wasn't hearing on this side, I put a bone anchored device on this side, and then when someone whispers on this side of my head, I could hear it on the other side. There are several different varieties of this type of device. The top image shows you a direct device. So the screw actually goes into the skull and sticks out through the skin. And then that's a transcutaneous device. And then there are those that use magnets, like the bottom picture. The magnet is not as good for people who've had acoustic neuroma surgery, because there's an artifact with the magnet. And this is really quite important. There are a variety of different devices that use magnets to retain themselves against the skull. But as you can see in this picture, if you have a magnet on the side of the head, the MRI that may be used for surveillance after acoustic neuroma surgery has an artifact so that we can't see that side anymore. And so it's critical to know that the best solution, if you're going to choose a bone anchored solution after acoustic neuroma surgery, is a transcutaneous device, or one that actually sticks up through the skin. And this is a very useful device. People have a lot, I think this is one of the most common ways that we rehabilitate hearing. People really enjoy this device. It works quite well. So then we come to the question of, well, what else could we do? So the problem with using a cross device or a bone anchor device is that you're really only using one ear. We're taking sound from the side that can't hear and putting it in the other ear. But that's not the same as having two ears. There are speech advantages of listening with two ears. One is that it improves the signal to noise ratio. What does that mean? That means when you're at a busy restaurant or at a party setting, you can actually hear the person you're speaking with over the din of the surrounding conversation and music. And this really makes a difference in conversation and background noise. So this 5 decibel improvement corresponds to hearing in noise scores from 43 to 76%. So that means you're doing a whole lot better with 2 ears rather than 1 ear when you're in a setting with background noise. So the way that this works is the ear uses the difference in the signal to noise ratio by using the 2 ears between the ears to identify what's not wanted and to actually suppress that signal. And the primary signal is better than if you get the signal in only 1 ear. And again, it's good for speech in noisy situations. This is often called the cocktail party effect. So in that situation where you have a lot of background noise. Another advantage is something that's technical term is binaural summation. Basically, you hear soft sounds better. You're using your 2 ears, you're focusing on a very soft sound, and it basically is centrally integrated from those 2 signals, and you basically have an increased perceptual loudness for very, very soft noises. And this is a huge one. So sound localization is probably the one thing that people who use cross devices and bone anchor devices complain about most. Because with a cross hearing aid or a bone anchored hearing aid on one side, you're only using 1 ear and you cannot tell where sound is coming from. So the way that we localize sound is it is a difference in when the sound hits 1 ear versus the other. So if sound is coming at me from this direction, it'll hit this ear before this ear, and then I know where it's coming from. So when I don't have 2 ears, I cannot localize sound. And this really translates into daily life. So patients with 1 hearing ear have trouble finding out where a loved one is calling for them in their home. They have trouble finding out where a car is coming from or other problem, that may be approaching them when they're outside on the street. And so sound localization is a big reason that people are looking for better solutions after acoustic neuroma treatment. So this is interesting. So this is where cochlear implants sort of come in. So as you can see, this is a little bit technical, but what we can see is localization error. So you're making more mistakes towards the top of this graph. And what we can see is that the last column is the cochlear implant column. So if you take a patient who can't hear in 1 ear and you put a cochlear implant in them, they make fewer errors than if you did a bone anchored hearing aid, which is the column next to it, or a cross hearing aid, which we also reviewed. And that's because the cochlear implant gives hearing back to the ear in question. And so you're basically working with 2 ears. So that is a real advantage of being able to use a cochlear implant in an ear that doesn't have hearing any longer. The other advantage of a cochlear implant is tinnitus suppression. So when we use bone anchored devices or cross devices, we route the sound, but we're not putting any signal into the ear that has lost hearing. And that doesn't really help with the tinnitus in that ear at all. What we know about cochlear implants is that they can actually be used as tinnitus therapy. And what this graph shows is when you turn on the cochlear implant, patients report that the tinnitus is less. And when you turn off the cochlear implant, the tinnitus can return. So this is another advantage of a cochlear implant. Now, this sounds all very well and good that we should use cochlear implants in someone after a vestibular schwannoma treatment, but it's really not that simple, because when we take out a vestibular schwannoma, we can affect the hearing nerve, and you need to have a cochlear nerve or a hearing nerve that works and that is intact in order to use a cochlear implant. And so we have done several studies at our center and with collaborators investigating when you can use a cochlear implant effectively after acoustic neuroma treatment. And so this paper, we looked at temporal bones after vestibular schwannoma surgery and found basically that if you do a hearing preservation approach, you're more likely to have a cochlea that is open and ready to receive a cochlear implant than if you do a translabyrinthine approach. So that's an interesting tidbit for if we are aiming towards doing more cochlear implantation after acoustic neuroma surgery. This is another paper that we were working on looking at cochlear implantation after radiosurgery. And we did a systematic review and basically found that the majority of patients who have cochlear implantation after a vestibular schwannoma or acoustic neuroma treatment do quite well. So almost 80% of them get open set speech, meaning that they can really understand words without a lot of other cues. Typically, the function of a cochlear implant is not quite as good after an acoustic neuroma surgery as it is if you did not have an acoustic neuroma surgery, and that is, or radiation. And that's because both radiosurgery and microsurgery do have effects on that cochlear nerve, and it's not in quite as good shape as one that hasn't been in a surgical bed or a radiosurgery bed. But at the same time, it is possible, and it is something that is being done more and more with pretty good efficacy. So just to touch on a little bit of balance work after surgery before we move along. So our goals with balance rehabilitation are to control the immediate vertigo. The way we do that is we control nausea, but we don't give things like Xanax or other vestibular suppressants because the body has to get used to the new normal. And if you suppress those dizzy signals, then you have a longer recovery. And that's a really important part of the process. And the key to almost all of vestibular recovery is vestibular therapy. We have vestibular therapists who partner with us and see our patients both in the hospital and outside the hospital after treatment. And they really help people, truly get back on their feet. So strengthen all the other systems so that patients can get back to their normal routine lives. The reason that it's a problem is that when we remove a tumor, it basically takes away the balance function on the affected side. And so what that means is we basically have an imbalance. So the body is looking for a signal that's no longer there because there is no balance nerve on the side of the acoustic surgery. And so you can run the airplane with just one engine. So after vestibular therapy and a bit of work, people get back to skiing, skating, bike riding, all the things that they really enjoy doing. We just have to get the brain to realize that it's just relying on one side. So perioperatively, again, we don't suppress the vestibular system. We make patients more comfortable with nausea medications. And then that physical therapy, I can't stress how important that is to getting people to recover quickly. What that vestibular therapy is doing is integrating visual information, muscle and joint information, and the remaining vestibular information on the other side to create a new normal so that the patient feels balanced. And this is Dr. Cho, our vestibular expert. He helps with vestibular ocular reflex testing and exercises, basically strengthening the connection between the eye and the remaining inner ear. Also muscle and joint exercises, so you know where your body is in space. And that's really a physical therapy focus. And then he always says that after 2 years, most individuals will have achieved most of their compensation. Some people recover more quickly than this. And it's really, part of it is how much you work on the balance is how quickly you recover. So with that, I'm going to hand it over to Dr. Lee, who will be speaking about facial paralysis.
All right, thank you so much. All right, so I'm Dr. Matthew Lee. I'm a facial plastic and reconstructive surgeon here at Cedars-Sinai. And so my role on the acoustic neuroma team is to get involved whenever there is a likely temporary weakness of the facial nerve after acoustic neuroma surgery. Now, thankfully, I'm not needed that often. And so it is, though, a testament, I think, to the thoughtfulness of a comprehensive acoustic neuroma program like we have here at Cedars, that we're thinking about all the different possibilities and how to manage them kind of proactively. And so that is my role on the team. Okay, advanced slide, please. Thank you. Okay, so generally speaking, when we look at any facial paralysis, whether it's after acoustic neuroma surgery or for any other reason, we kind of break down sort of the time course of a facial paralysis into kind of three distinct sort of time frames. The first is sort of being the acute phase, which is, within a year. This is the time period where, we're fully expecting that the nerve is going to recuperate. When we get to around the 1 to 2 year mark after onset of a facial paralysis, then that's when we start to think about, well, if the nerve isn't coming back, what are the interventions that we need to think about at this time course? And then finally, really for the late stage ones, where if we haven't been able to see a patient or do anything for the first 2 years after onset of a paralysis, that does change some of our options that we have for intervention. Advanced slide, please. Sort of the key concept that I like to think about here is what I always say is time is muscle. And so what this really means is that the longer that your facial muscles go without neural input, without power, that's the time period at which they're not contracting, they're not moving, they're not active. And so over time, like any muscle that doesn't get used, they tend to atrophy, or they get thinner and weaker. And over a certain time period, they no longer become functional. And so that's the reason why it is important in any facial paralysis that a facial plastic surgeon or someone that is capable of managing a facial paralysis injury is able to get involved early, so that we're intervening at the appropriate time. Okay, next slide, please. So in the acute setting, the main thing that we're thinking about really is the eye. The eye is paramount. It is at the top of our list of everything that we're thinking about. And the reason is that even with the temporary paralysis, short periods of time of facial paralysis, if you're not able to blink the eye, can lead to some long-term consequences in terms of the vision. And the reason for this is that the primary point of a blink is to protect the surface of the eye by distributing what we call a tear film across the surface of the eye, or the cornea. Now, in cases of facial paralysis, the nerve that controls the face is responsible for closing or blinking the eye. The muscle that, and the nerve that opens the eye is left completely intact. So you can open the eye perfectly fine. You just can't really close or blink in many cases of facial paralysis. So when that occurs, we're not having a distribution of that tear film across the surface of the cornea. The tear film is a very complex structure. It actually has 3 different layers to it, and it's responsible for retaining the moisture on the surface. So if we're not able to blink, the surface of the eye can become very dry, and over time it can lead to scar tissue formation on the actual cornea, which over time can actually result in vision loss. And so it's really critical that we pay very close attention to the eye, even in the short term, the first few weeks after onset of a paralysis. Advanced slide, please. So, thankfully, the options that we have to treat this are very simple. So the mainstay of treatment is really moisturization. And so what we have you do is, if you are unable to blink the eye completely after the surgery, first of all, reassure that, this will get better, in the vast majority of cases. And in the meantime, while we're waiting for the nerve to recuperate, we want to make sure that we're using eye drops. And so there's, any number of different moisturizing eye drops that are all freely available, or not freely available, but available openly over the counter. And so these are some examples here, things I just found on Amazon for you guys. And so these moisturizing eye drops, it's important to use them every couple hours or so in order to really lubricate the surface of the eye. And that's kind of during the daytime. Now, at nighttime, what we usually recommend are lubricating ointments. Now, these ointments are much longer lasting. They have a longer impact on the moisturization on the surface of the eye. But because they're a little more viscous, a little bit thicker, they can cause some blurriness, which is the reason why we primarily use it at nighttime before bed. And then kind of the third prong to that treatment is really doing what we can at nighttime to prevent evaporation of moisture from the eye. So whether that's taping the eye physically shut with some medical tape, or using something called a moisture chamber, which is really like a one-eyed swim goggle. And what it does, it creates a pretty tight seal around the eye, which helps to reduce the amount of evaporation that occurs from the surface. And so I usually like to take this 3-pronged approach: eye drops during the daytime, lubricating ointments at night, and then the third part is either taping the eye shut or using a moisture chamber to prevent evaporation, or doing both. Next slide, please. And so let's say, for example, that that there is a little bit of facial weakness, not able to blink, and that we're being very, very, very vigilant with all these different eye drops and all ointments, taping the eye shut. But let's say a few months have gone by, and now the eye is starting to look like this. And so what you're seeing here, this is what we call exposure keratopathy. Now, the big question is, well, if we're doing eye drops and ointments and taping, why would this occur? And there's multiple factors that are involved here. One is that there is a natural variation in terms of how much, how dry each individual's eyes are. Some people produce, really, robust tear films. Other people just naturally have drier eyes. And so if you do have drier eyes, you're more at risk for developing these types of complications. And the second part to this is that anything that we can do in terms of artificial tears or ointments, they can't actually perfectly replicate the protective effect that occurs with an actual blink. And so while they are good sort of temporizing measures while we're waiting for the nerve to recuperate, over time, over longer time courses, it just can't quite replicate that same protective mechanism. Because if you think about, how often you're blinking, on a day-to-day basis, I mean, you're blinking every, 10 seconds, every few seconds or so. Whereas we're applying these ointments and eye drops, not at that frequency. And so that's part of the reason why these still can develop, even if you are being very diligent with all their treatments. Next slide, please. So that's where we start to think about, well, what are some of the surgical treatments that we might do to help protect the vision of the eye and to protect sort of the surface of the eye from drying out? Thankfully, the surgeries that we offer at this point are very simple and straightforward. And so the way I think about this is that your eye is actually capable of closing in two ways. Okay, one is the active closure that occurs with a blink, and that's with either soft or forceful blink. The second is a passive closure that occurs just by the weight of the eyelid. So like I had mentioned a little bit earlier, the nerve that opens the eye is actually intact, right? The nerve that the muscle that opens the eye is intact. So just by relaxing that nerve and that muscle, the eyelid will drop slowly with time just by gravity. Now, this is what occurs actually when you sleep at night. You're not actively closing the eyes, it's just dropping by gravity. Now, the problem is that the time course of a blink is a fraction of a second. That doesn't give the upper eyelid enough time to fully close. And so the upper eyelid is simply not heavy enough. And so what we do in these cases, if the nerve is not returning after, their nerve function is not returning after a few months and we're still not able to blink, we consider what we call an upper eyelid loading procedure. Now, this is a procedure very simple where we make a small incision on the crease of the upper eyelid and we implant a weight, usually made out of platinum, to the upper eyelid that actually weighs the upper eyelid down and allows it to close much more rapidly just by gravity. And so, sometimes that in and of itself is enough actually for us to get the eye to close. And you'd be amazed that once we reestablish a blink, that the health of the surface of the eye will oftentimes very rapidly improve because, like I had mentioned, a blink is much more protective than eye drops or lubricating ointments. Next slide, please. The second aspect to this is that with any kind of facial paralysis, the lower eyelid also becomes a little bit weak and it can sag a little bit. And that's because the muscle that normally keeps it up and taut is weak. And so if the lower eyelid does start to sag, there's a procedure we can do, a lower eyelid tighten procedure that we typically do from a small incision that's about 1 centimeter right at the corner of the eye. And it's sort of like belts and suspenders. What we do is we take the lower eyelid and we pull it up under greater tension, and we sort of suspend it at a higher position that allows greater tension. That, again, helps with the distribution of the tear film evenly across the surface of the eye. Both these procedures are done are very short little procedures that are done in the outpatient setting. Next slide. Okay. So let's say that we're kind of, let's say that we've made it through the first few months, getting closer to a year, and we're not really seeing that the nerve function is coming back. Again, to emphasize, this is a very uncommon scenario, but to kind of go through what are the different options at that point. Well, we start to enter this period where we call chronic facial paralysis, but still with viable facial muscles. Now, remember, the longer the facial muscles go without neural input, without that electrical power, the weaker they get. Before the 2-year time point, however, they're still serviceable, meaning that if we bring new power in, those muscles are still ready to work. They just need some neural input. And so next slide, please. If we're getting to the point where we're closer to a year, we haven't seen function back, and we're starting to think, okay, maybe there might be a little bit of a longer-term paralysis involved here. This is where we can jump in with what we call re-innervation procedures. And what this is doing is that the facial nerve, typically here in the periphery, meaning like closer to the actual muscles, is actually anatomically intact in most cases. What it needs is power. It needs something to actually send the electrical input through. If it's not getting it from the brain because of the disruption from, swelling from surgery and things of that nature, we can actually find alternative donor nerves that we can transfer over to the facial nerve to actually power the nerve. And there's two different nerves that we use to accomplish this. That's the hypoglossal nerve, which is a nerve here in the neck that controls the motion of the tongue, as well as the masseteric nerve. It's a nerve right up here in the face that is one of the nerves that is responsible for some of the bite control. Next slide, please. And so what we oftentimes do in these cases is what we call a dual nerve transfer or a two nerve transfer. And what we do is we use a facelift type incision that heals typically very well. It's hard to see because it conceals right in the junction of the ear and the face, usually extending down into the neck. And that what we do is we find the branches of the facial nerve, and then we find our donor nerves, and then we coapt the donor nerves to the facial nerve. Next slide, please. So the first thing that we do is we find specifically the branch that is responsible for the smile, because the smile is one of the most critical things about restoring facial motion that helps the face to look normal again. When you can have a spontaneous symmetric smile, that's critical to people's quality of life and to their expression. And so we find the nerve that's responsible for the smile, and then we go and we find the nerve that's controlling sort of the bite function, the masseteric nerve. It's the nerve that controls this muscle here that is responsible for chewing. We disconnect the nerve from that muscle and we reconnect it to the smile branch of the facial nerve. And this allows us to create what we call a bite to smile function, where when you're trying to smile, you smile normally on one side, but on the side where there's the weakness, in your head, you're thinking to bite. And what it does is actually, because the nerve has been rerouted, you will actually smile instead. And so it's a bite to smile function that over time can actually become very natural for people, and they can do with some physical therapy and training and coaching. They can actually do sometimes over time spontaneously without actually thinking about it. It becomes second nature. Next slide, please. And so the second nerve transfer that we would do is a graft that connects one of the nerves down here in the neck that controls the tongue. We do a graft that actually connects it to the main branch of the facial nerve. Now, this nerve graft is not actually intended to provide motion, but what it does is it provides baseline neural tone. What this means is that at rest, we want a certain level of neural tone that prevents the face from going flaccid. We want it to have a certain amount of tension that keeps the face into a symmetric position. And so that's the purpose of the second nerve. So, one nerve graft is done to recreate the smile. A second is done to create tone so that the face can look more symmetric at rest. Next slide, please. Okay. Now, if let's say, for example, that there's been a paralysis and that it's going on greater than 2 years, and we haven't had any sort of intervention as of yet. In these types of cases, well, the paralysis has been present for long enough that the facial muscles at this point are what we call atrophied, meaning that they haven't been stimulated, so they kind of wither away, and they're not really actually functional at this point. Next slide, please. So in this extremely rare scenario, if we haven't been able to do anything within the first 2 years, we actually have to bring fresh muscle into the face in order to actually restore that smile. And so typically what we do in these cases is what we call a gracilis free flap or gracilis microvascular free tissue transfer. And what we do is the gracilis is a muscle in the thigh, sort of thin band-like muscle. And then we take the muscle from the thigh, again, through a facelift type incision, we transplant it to the face, and then we connect it to an artery, a vein, and a nerve in the face to transplant new tissue. So you can go ahead and advance for the next, I think, 2 or 3. That's the gracilis flap coming up to the face, insetting it into place, connecting it to the nerve, artery, and vein. Next slide, please. So now, again, thankfully, that's a pretty rare scenario. We've kind of gone over worst case scenarios where the nerve, is not recuperating over certain time periods. Now, like we had mentioned in the beginning, the vast majority of cases of facial paralysis will resolve within the first few weeks to months, the vast majority. Now, that being said, sometimes when they do come back, they come back with a little bit of abnormal function. You can kind of see 2 things. One is what we call dystonia, where the face feels almost too tight or spastic. And the second is called synkinesis, where you're trying to move one part of the face, you accidentally move others. So as an example, you're trying to smile and your eye kind of blinks at the same time. Next slide, please. And so kind of on this diagram, what you're seeing here is we're shading out the normal part of the face. This would be an example of sort of a dystonic and synkinetic smile. Next slide, please. Now, thankfully, this is very easily treatable actually and doesn't require surgery. We can actually treat this with Botox injections. And what we do is injecting both to the side that's affected, as well as sometimes to the unaffected side to actually produce better symmetry and improve the function. And we can inject kind of to the forehead lines. We usually inject around the eye. We inject sometimes to around the lip as well as the neck bands. Next slide, please. Okay, thank you so much. So we'll move on to the next portion of the presentation. Will be Dr. John Yu.
Can we switch the picture? And you, this is Dr. Yu. Can you put my picture there? I guess we're having some technical difficulty. Are you able to put my picture up as I speak?
We can see you, John.
Oh, you can? Okay.
Yeah.
Very well. My name is Dr. John Yu. I'm the neurosurgical director of the Acoustic Neuroma and Lateral Skull Base Center, and it's my pleasure to present neurosurgical complications after acoustic neuroma surgery. Although we have a world expert on facial reanimation in Dr. Lee, thankfully we haven't needed his services so far, knock on wood. But it's great to have that capability here at Cedars and to have the full armamentarium of a toolkit to treat all the types of complications. Next slide. I'm going to show you here the actual surgery for a retromastoid approach to remove a acoustic neuroma with hearing preservation. So as we do this, we find the facial nerve and we stimulate on the surface of the tumor to find it. We internally debulk the tumor so as to give ourselves some room to remove it. Then our ENT colleagues, Dr. Miller, would remove the tumor from the internal auditory canal where the nerve goes into the bone after she drills off the bone. And then we'll remove the cisternal part of the tumor, or the part that goes into the brain. And we carefully remove the tumor and preserve the facial nerve as well as the auditory nerve so as to preserve hearing as well as facial strength. And this is the best of surgery, and this is how surgeries should normally go, but there are some complications that we do see. Next slide, please. One is that there's a possibility of infection. There's a possibility of cerebrospinal fluid leak, either from the ear or from the incision. There's risk of hydrocephalus and headache. Next slide, please. With regard to infection, you can have a superficial skin infection, and these are generally treated with oral antibiotics at home, and generally with a week or 10-day course. This should take care of it. In a few circumstances, one may get a meningitis or an infection of the fluid or the CSF of the brain. And this is treated with antibiotics, usually IV antibiotics in the hospital, and then subsequently with IV antibiotics at home. When a patient presents with an abscess of the brain or an abscess or infection of the brain itself, this is normally treated with surgery to evacuate the abscess, and then with antibiotics for 6 weeks, IV antibiotics that are started in the hospital and then at home. The symptoms for these are generally obvious in terms of fever, redness along the skin, and sometimes some pus from the incision. Thankfully, this is a rare complication, occurs generally less than 1% of cases. Next slide, please. Cerebrospinal fluid leak is another potential complication. It can come from the ear, which is known as otorrhea, or from the nose, which is known as rhinorrhea. This is treated with a lumbar drain in the hospital. It's like a spinal tap, except a drain is placed in the cerebrospinal fluid of the spine. Usually with 3 days of treatment, patients will have their CSF leak stop and then can avoid an operation. However, if the CSF leak persists, then the patient may have their incision sewn over so that the leak doesn't come out through the skin. And if this is not sufficient, then they may need a reoperation to close the region from which the CSF leak is happening, usually from the bone, where one usually uses wax to stop a fluid accessing the ear. And if this doesn't help, then the patient may undergo another operation called a ventricular peritoneal shunt or a VP shunt to shunt the fluid from the brain to the belly, where it's absorbed and allows the pressure to remain normal so that the CSF leak will be successfully treated. One can also have hydrocephalus, which is an increase in the ventricles or the fluid containing part of the brain. And this can be caused by a large tumor that blocks the flow of the fluid out of the brain, or it can be even caused by tumor cells that block the absorption of the fluid from the brain. And in either of these cases, it can be treated again with a ventriculoperitoneal shunt. Next slide, please. Patients can get headaches. Usually incisional pain is normal for 3 or 4 days after surgery, and this is well treated with narcotic pain medication, transitioning to Tylenol. Headaches can occur from a CSF leak by a low pressure headache, and these can be somewhat debilitating at times until the CSF leak is treated. One can also get an entity called occipital neuralgia. If the occipital nerve is transected with the incision, then sometimes this can cause a pain near the back of the head. And this is usually treated with either injection of the nerve or by transection of the nerve in a more regulated fashion. Next slide, please. So radiosurgery is another alternative to surgery, and this is used to stop growth of the tumor. It generally doesn't eliminate the tumor, but it keeps it from growing larger. So often there's temporary swelling after the radiosurgery treatment, and this can look as if the tumor is actually growing when it's not. It requires long-term surveillance with serial MRIs, and long-term hearing is generally poor. Next slide, please. To minimize the effect on the surrounding tissues with radiation, the beams are focused on the tumor to reduce the radiation that the rest of the brain receives. There are less upfront risks than surgery, and the long-term control is good, with about a 90% control rate at 10 years. This is often used in patients that are older, or with patients who have a lot of medical problems that prevent them from having surgery. Next slide, please. However, after radiosurgery, microsurgery, should the tumor grow, does become more complicated, with a less likely possibility of a complete resection, and complications are more likely in surgeries after radiosurgery. Next slide, please. The goals of care is to treat the tumor as soon as it's shown to grow on successive MRIs. There's also controversy as to whether microsurgery is superior to radiosurgery in terms of vertigo and balance when a patient has dizziness prior to treatment. To minimize the risk in balance, we recommend evaluation by a balance expert. Our resident balance expert at Cedars is Dr. Ted Cho, who's a world expert on this entity. Long-term hearing preservation is unlikely in patients who undergo radiosurgery. but because microsurgery after radiosurgery has a higher complication rate, one normally considers microsurgery in younger patients rather than radiosurgery. Next slide, please. Complications after radiosurgery. Again, the loss of hearing is an expected outcome after radiosurgery. Radiation necrosis is caused by radiation's injury to nearby tissue. There's a steep fall off of radiation from the tumor, but it does give a substantial dose sometime to the brainstem and the cerebellum, and this can cause what's called radiation necrosis, which is injury to the brain. And this is normally treated with steroids. And if steroids doesn't control the swelling, then one may have to do surgery in the interim. Next slide, please. And that concludes the neurosurgical complications portion.
Thank you, John, and thank you, Matt, Drs. Lee and you. We wanted to just see if there were any questions from the audience, or we also had a few things that we had questions for each other. I had one for Dr. Lee, which is patients ask a lot of the time when you're first finishing treatment right after surgery, is there a difference between having a facial weakness immediately and one that's delayed?
Yeah, that's a great question. It's a very favorable sign when the facial paralysis or the facial weakness is delayed in onset. So if after the surgery things look good, but then maybe day 2 goes by and you're starting to develop some weakness, that's actually a favorable sign, because what that tells us is, by definition, is that the nerve is working, the nerve's intact. It's just swollen. It's a little bit stunned from the trauma of the surgery. And swelling oftentimes peaks a day or 2 or 3 after the surgery. It's not as obvious immediately. And so that delayed onset of facial weakness is definitely a favorable prognostic factor, because we know it's just swelling, which means we know it's going to get better.
Thank you.
We've got a couple of patient questions. If we could just jump in. One is, Dr. Miller, you had touched on cochlear implants and bone anchor devices, and we're hearing a little bit more about combining the AN surgery and an implant at the time of surgery. Can you tell us a little bit more about that, and who might be good candidates for that?
That's a really tricky question. For one, when you're talking about doing a cochlear implant at the same time as acoustic surgery, there's a couple different considerations. One is that it adds time. These are already pretty lengthy procedures. But another is that you don't know the hearing outcome 100% at the time of surgery. So if you're doing a hearing preservation approach, for instance, and you lose the signal that we follow for hearing, that doesn't always mean that you've actually lost hearing. And so one disadvantage of doing something like a cochlear implant immediately is you don't actually know the final hearing results. There are some investigators looking at ways to test the nerve intraoperatively. In my mind, before entering the cochlea, which can cause hearing loss with a cochlear implant, I would really want to know the final hearing result in a hearing preservation surgery. So waiting just a few months and getting that final result, I think there's very little downside to doing that.
Okay. I wanted to touch on dizziness. I know a few of you had talked about that. Is that more associated with any particular treatment at all, or is it based on more on the patient and in their situation?
I think it's both. I think that patients, one thing that our Dr. Cho talks about is that patients who have a predilection to imbalance and dizziness problems, they can have a more difficult recovery. So someone who carries another diagnosis like vestibular migraine or something else going on, it can complicate that recovery time. But there is controversy, just as Dr. Yu said, whether, if someone is dizzy with an acoustic neuroma pre-treatment, should they get radiosurgery or microsurgery? And there are experts who fall on both sides of that. John, do you have an opinion on which is better for dizzy patients?
I think it's more dependent on whether they're dizzy to begin with, whether they'll be dizzy after a treatment, regardless of the treatment. So I think that has a bigger bearing than anything else, even the treatment itself.
Sure. Dr. Lee, you had mentioned, you were talking about some eye issues there. How common are post-operative eye issues? there were it was great information, but I'm sure patients would probably think, well, gosh, is that going to happen to me? And what plays into that?
Yeah, and so the numbers that are reported for sort of temporary facial weakness are kind of widely vary across the literature. So I would actually maybe let Dr. Miller and Dr. Yu kind of comment on some of their experience. Now, the good news though is that when it does occur, actually the vast majority of cases, even when people have a complete inability to blink, what we call lag ophthalmos, most of those don't actually require surgery to correct, because most of the time, when you are very, very kind of diligent with the eye drops, with the lubrication ointments, with the eye taping and the moisture chambers, I have sometimes seen, patients that not after this surgery, but people with just like Bell's palsy or Ramsay-Hunt, other types of facial paralysis, where they can go months actually, with an inability to blink the eye, but because they're so good with their moisturization regimen, they're actually doing fine. So it's very few and far between to ever see any patient have a actual impact on their actual vision in terms of vision loss, unless they're just really not being or weren't educated on or are not being compliant or consistent with some of their moisturization regimen. Yeah.
Okay, we're hearing more and more about patients asking about fatigue after treatment, and can you comment a little bit about the difference between radiation and surgery and how long that might last for patients? How often do you see that going on?
Yeah, so I think fatigue is a very patient dependent, and oftentimes acoustic neuroma surgery is a several-hour surgery, 8 hours plus in some cases for very large tumors, and so patients undergo a relatively big trauma, and so they're going to be fatigued after for a couple of weeks or even longer. So it's not surprising that they have that, but I'd say some patients jump up right after surgery, go home and are exercising pretty soon after that. So it's very patient dependent. Radiosurgery, patients will come out of it and feel pretty much the same as when they went in. I think it's more the stress. Sometimes patients get treated over the course of 2 weeks, and so it's the coming in and out, waiting for their treatment and coming that they'll often feel fatigued. And sometimes the inflammation associated with the radiosurgery may contribute to that as well. But I'd say in general, it's a less prevalent thing among radiosurgery patients.
Okay. All right. Now here's a question we probably should have started at the beginning of this is, is there anything patients can do to prepare themselves leading up to when they've made the decision for treatment? What would you suggest maybe that they do leading up to that to have the best outcome for all of this?
So Dr. Yu and I talk about this quite frequently. I tell patients, well, number one, smoking is bad for any surgery. So I will let patients know that really is difficult. It impedes the blood supply to the healing area. So even decreasing that, if you cannot quit, is critical. But also just being in the best shape that you can. So if you are, able to walk and you are routinely moving around before surgery, it's easier to get up out of bed and start that movement that begins your recovery. So I think that being, not super active, but definitely active and making sure your body's in good shape and ready to tackle recovery is important before surgery.
Okay, that's all the questions that we had on our end. This has been absolutely terrific. We really do appreciate you joining us for this, Dr. Yu, Dr. Miller, Dr. Lee. Thank you so much. You all do so much for us and for the AN community. It's been just a pleasure having you here. Thank you for participating with us.
Thank you for having us. It was a pleasure.
Thank you.